It's U of L Today on 93.9 The Ville. Here's your host, Mark Hebert.
And welcome to U of L Today with Mark Hebert on 93.9 The Ville. This is the show about all the really good stuff going on at the University of Louisville. So we'll be talking a little research today, and we'll be talking hopefully about stuff that you'll be interested in. Stick around for the next half hour or so. On the show today, how did humans disperse from Africa to the world beyond? An anthropology professor has been taking U of L students to Africa to help unlock some of those mysteries, and we will talk to him. And you go to the emergency room seriously ill and you find out you've got sepsis. What are your chances of living, and how do those chances increase with a quick administration of antibiotics? We'll talk to a couple of U of L doctors about their study on that. But first, you know about the heroin and opioid abuse epidemic going on in our country, and in particular Kentucky and southern Indiana. But who are the people abusing these drugs? Are they mostly city dwellers, or are they from rural areas? Dr. Martin Huecker is an assistant professor of emergency medicine at the University of Louisville and also works in the ER at University Hospital, and he's here to talk about it a little bit. Martin, good to see you again.
Yeah, thanks for having me.
Sure, always great to see you. All right, you work in the ER.
Yes.
You work with students, and you've seen an awful lot of folks that have come into the ER with overdoses in the past several years. So where's the epidemic as we stand today on the heroin and opioid abuse epidemic?
Well, as far as today, right now, we kind of don't have a great picture. It seems to be decreasing as far as ER visits are concerned, but the overdose deaths in the state are plateaued. They have not started to decrease yet. We hope that the House Bill 1 legislation will make that happen as we kind of get the pills out of their hands and people don't get initiated into opioid addiction, that maybe we won't see as much heroin overdose and as many deaths from that. But it feels, kind of like ER visits not counting in the past year, it does feel like visits might be decreasing a little bit.
So they may be going down, so that's a good sign. But you've done a lot of studies and a lot of research on this over the past, 5-6 years, something like that. Right. What have you found? What's the gist of it?
Yeah, we started with the big study, which you and I think have talked about before, that looked at what happened with House Bill 1. And so we saw that...
And House Bill 1 was what?
It was the legislation that basically made opioid prescribing a little more difficult. Only 3 days supply. You had to... everything was documented. You had to run a Casper query, which shows all controlled substances prescribed in the state. And so if you were thinking about giving pain pills to an ER patient, you had to go through some hoops to do that. And so we saw that after we initiated that bill, heroin overdoses were skyrocketing. And that's what we decided to study. So we looked from 2009 to 14 and saw that, yes, indeed, right after the bill was passed and in the next few months as it was enacted, we saw a lot of heroin overdoses. They just skyrocketed. So we published that a couple years ago. Then we decided to kind of dive deeper and look by region, so by urban, suburban, and rural areas where people were coming from. So this wasn't where they overdosed and died. This was their address when they where they lived when they came to U of L's ER with an overdose visit. So we looked at pill overdoses and heroin injection overdoses, and we saw some interesting things. We did see opioid pill overdose visits and pill overdose visits did increase from about 2009 to 2011, but right when the legislation was enacted, we did see pill overdose visits decrease for the next few years, only though in urban and suburban. So folks who had rural addresses, we did not see that decrease. So it almost looked like the folks were coming from rural areas around town, that maybe the pills were sort of filtering out there, or maybe pills were coming from eastern Kentucky. That's all kind of speculation, but one thing that we did see that was interesting was all three urban, suburban, and rural, we saw increases in heroin overdose visits. So everyone kind of turned to heroin across the area, but they still had a lot of pills out in the smaller areas around town.
And it sounds like, from what you're saying, you just looked at University Hospital, correct?
Right, only looked at our hospital.
ER.
Yes.
So these are the folks coming just to Louisville to be treated in the ER for overdoses or whatever.
Right.
Was it just
overdoses?
Yeah,
it wasn't only overdoses. We had some subsets that we looked at only the overdose, but it could be any pill-related complaint. Most of them were overdose or intoxication, or they were found on the ground. But there were a few people seeking treatment, or maybe they had a needle in their arm. There are so many different complications we are seeing related to it. But yes, it was mostly overdoses.
So we're talking to Dr. Martin Huecker, who's an assistant professor of emergency medicine at the University of Louisville. We're talking about the opioid and heroin abuse going on, and southern Indiana and Louisville, Kentucky, in this general area. So I guess what you're saying is the bottom line is heroin overdoses and the use of pills were going up with everybody, but it was going up at a substantially greater portion in the back half of your study in like 2013, 2014 from rural areas. So these are folks from perhaps Shelby County, Meade County.
Yeah, a lot of south of here, kind of Bullitt County.
Okay.
Yeah.
So what's that tell you? I mean, what can you take from that?
We had a few conclusions from that. One that we can think about is resources. So how do we allocate resources to people who really need help? And needle exchanges, rehab centers, Suboxone medication assisted treatment centers. There are a lot less of those in areas around large cities. So that could just further argue for a need for these resources to be allocated kind of outside of city area. Because in downtown Louisville, in fact, our treatment centers are mostly in 40202. And we did have a lot of visits coming from that address because people are staying in a rehab center and slip up and overdose and come in. But we still saw all these people still using pills and using a lot of heroin in the surrounding area. But so we probably need more treatment centers. Whether or not you agree with needle exchanges, that's a conversation we all need to have on getting resources out there to people.
Yeah, this is UofL Today with Mark Hebert on 93.9 The Ville. We're talking to Dr. Martin Huecker from the University of Louisville. So right now, what's the trend? Is there something new coming out there, some new drug? We've talked about fentanyl before,
yes.
How deadly that can be and what a troublesome drug that is. Is there anything else that is suddenly showing up in the emergency room at University Hospital as some new drug?
Well, great question. It's not a new drug, but it's an old drug, meth. So crystal meth, methamphetamine seems to be, it had always been sort of paired with heroin, and people, if they couldn't get heroin, would use some meth, or if they're really low from the heroin, they might use meth to kind of come up. But we're seeing a lot more of it now. At least every shift, I'm seeing 2 to 3 patients in with meth intoxication, or maybe they are just withdrawing a little bit from it. That's not as bad a withdrawal syndrome as opioids. But so yeah, meth's kind of the new player. And that's especially prevalent in southern Indiana from talking to our docs at Floyd and Clark hospitals.
That is not good. And there's no quick treatment for meth overdoses, is there?
Exactly. And in a way, they are more difficult to deal with because they will be very agitated. You can have small heart attacks happen. You have to sometimes restrain people to protect them from themselves, use a lot of medications to calm them down. Whereas with a heroin overdose, if you live to make it to the ER, naloxone, the reversal agent, gets them breathing again, and they do pretty well. So, yeah, meth's kind of getting to be a tough one for us.
Well, what's your next study coming up?
Well, right now we're submitting a new manuscript based on that same data set to look at naloxone reversal. So we took out of all those patients, we looked at just the people who had heroin, who overdosed on heroin, and who got naloxone, Narcan, the antidote, and we're trying to look at when it's safe to release them from the ER. So the textbooks say anywhere from 4 to 24 hours. So if we kept every heroin overdose for a whole day, that would be very difficult. So we looked and we found that at about the 2-hour mark, that's a fairly safe time to complication rates. But then in that 2-hour to 3-hour length of stay period, we still had a significant amount of people that needed oxygen or that needed another dose of Narcan, because Narcan doesn't last as long as heroin or especially the pill opioid. So we're sending that in and trying to get that published. And then the one I'm very excited about that we're kind of crunching all the data now is looking at all the people in the state who have died of opioid overdose, any opioid. And we've looked at that from really up to about middle of 2018, going back a couple years. And what we want to do is find out where they hit the system. So we're looking at EMS runs, hospital visits at UofL and Jewish and wherever else we can get that approved, looking in the justice system. So looking at folks who maybe were incarcerated and right when they get out, very high risk time. So we like to try to kind of make a predictive algorithm. You were EMS 2 days this week, you just got out of jail and now you're in the ER, you're at very high risk of dying this week or next week, and we want to save your life, basically.
Because based on prior statistics, your number's potentially up if you keep doing heroin.
Exactly.
Or opioids.
Right. Okay. And with all the fentanyl in the area now, a New England Journal just published a series of cocaine mixed with fentanyl, basically, and had multiple patients come in. And so, it's still very prevalent here and in other states, and we're doing everything we can to kind of tackle it.
Yeah. All right, Dr. Martin Huecker. The interesting thing that he brought up here was that meth is on its way back up here in our area. So let's hope you and your fellow ER physicians don't have too many deaths on your tables as they walk into the emergency room.
Right.
Okay, Dr. Martin Huecker from the University of Louisville, Assistant Professor of Emergency Medicine. Appreciate you being on the show again. With me now is Amanuel Beyin. He's an Assistant Professor of Anthropology at the University of Louisville, and he has studied human flight and human movements around Africa, particularly the coast of Africa. Amanuel, good to see you again. How are you?
Oh, I'm good.
All right. Well, let's talk about your research. What specifically are you looking at in terms of humans and Africa and their movements in Africa?
I'm interested in how our ancestors left Africa. For a long time, our ancestors remained confined to Africa. At some point, they left Africa and colonized the rest of the world. And so the questions that researchers are trying to figure out at this point in time include when these dispersals start, how many dispersals did it take for our ancestors to migrate out of Africa as a viable population and occupy the rest of the world, and through which dispersal routes or through which specific geographic regions did our ancestors migrate out of Africa. The region where I'm conducting my research at the moment is the western periphery of the Red Sea. And
where is that? What country is that?
In East Africa, there are three major countries that borders the Red Sea: Eritrea, Sudan, and Egypt. And so it is this coastline that markedly that marks the northeastern borderline of the Eastern African landmass.
Okay.
And so that makes it special because it's the only coastline that connects the main East African landmass with Southwest Asia. So this region, I hope, will give us some clue as to whether our ancestors used this coastal dispersal to live out of Africa, Africa. And how this coastline basically, or adaptations to the coastline relate to the adaptations that occurred in the mainland.
Okay. I'd be remiss if I didn't ask you where you're from. Where are you from?
I am original from Eritrea.
Okay, so that's one of those countries right
yes,
there that you talked about. Yes, it's
one of the countries that has a long coastline along the Red Sea, more than 1,000 kilometers. And so the first research that I developed, or project that I developed for my dissertation work, was about 13 years ago, and I surveyed and excavated sites, Stone Age sites along the Red Sea coast of Eritrea, and I found sites that appear to be promising to show that early humans at least lived on the coast, and potentially one of these inhabitants may have served as source populations for those populations that ultimately left Africa.
And we're talking thousands and thousands and thousands of years ago.
Yes. So
how long are you looking back? I mean, seriously.
My target timeline is anywhere between about 1.8 million years to 50,000, because we have two crucial events there. One is dispersal by Homo erectus, the first fully bipedal species who migrated out of Africa and left its footprints in Asia and parts of Europe, and all the way to East Asia. So we have evidence of Homo erectus living in China, dating about to
that's a long way to get from Africa to China.
Yeah, 1.5 million years ago, and Indonesia. So it makes you wonder, when did this dispersal happen out of Africa to lead to humans occupying the China? And the next major phase or event that happened between this time, the time span, was the migration of our lineage, Homo sapiens. So we're talking about two major lineages, Homo erectus and Homo sapiens. And the dispersal of Homo sapiens is particularly important because that dispersal led to the colonization of the entire world, the entire our planet, including the Americas.
Right.
And it happened over several centuries.
Yes, over several centuries, and it might have involved multiple waves of migration. Right. Some of them may have failed, some of them successful. So we should conceive dispersal as this piecemeal process where at times our ancestors did not even know where they are going. They were just looking for stable habitats and vital resources for their survival. And as they did so, they were just probably following their prey animals, and that led to, fortunately or unfortunately, to the discovery of many new territories where they have ultimately established their presence.
Again, we're talking to Amanuel Beyin, who's an assistant professor in anthropology here at the University of Louisville, and he has studied how man essentially got out of Africa and spread around the world. You know, I think a lot of us as Americans, we don't have a history that goes back that far. We only think of slavery, of African Americans coming out of Western Africa into the United States and other parts of the world as slaves, and that's the dispersal that we immediately think of. We don't go back the millions of years, or the 1.6 million years, and talk and even think about, you know, going to Americans going to Asia, Israel, Europe, you know, all over the planet.
Yeah, so, you know, the concept of dispersal is very crucial here. You just mentioned that we might just have a very narrow, you know, perspective of dispersal, just, you know, as if it happened just recently. But dispersal had been just part and parcel of our evolutionary journey. Throughout their history, humans have always been wanderers, always looking for new territories to live on and explore new survival opportunities. When their native territories become no more stable. So, yeah, dispersal is still happening. So the concept of dispersal still is guiding human survival. All these, you know, issues of migration, refugees, wars, all tied to human need and humans exercising that adaptive strategy to look for opportunities outside of their niche when their niche is not sustainable anymore.
What do you hope you will find off the Red Sea coast that will, and what do you do with it once you find it?
Well, currently there are two major projects that have been involved within the Red Sea. One is the project that I developed like 13 years ago on the Red Sea of Eritrea, on the Red Sea coast of Eritrea, where I've documented sites that are estimated to be between 1,500 to 50,000, 150 to 50,000 years ago, which is a time range that brackets this dispersal of our Homo sapien, our lineage, the Homo sapiens. And just recently, about a year ago, I've initiated a new project on the Red Sea coast of the Sudan, where my team documented sites that appear to date about 1.5 million years ago, based on the...
And what did you find at those sites? When you say we've documented sites, what did you find?
Did
you find human bones or human...
mainly stone tools.
Stone tools, okay.
You have to be very lucky to find fossil remains, you know, and
Right.
these two projects are still at their young stage, and we're hoping that we'll find fossil remains. But so far, what we found are stone tools that are characteristic of this time periods where we know when Homo erectus lived, when our immediate ancestors, Homo sapiens, lived, and we can tie this archaeological evidence with those time periods and events that that were important for human migration out of Africa.
How do you use this in your classes? What do you teach your students? How do you take that evidence that you've got of these civilizations that were around the Red Sea back then, and how do you put it in your classroom at the University of Louisville?
I teach several exciting classes that allow me to incorporate...
Of course they're exciting.
Yeah, well, anthropology
right?
is exciting in itself. So, and I teach a class called The Emergence of Human Culture, where I am able to basically pull a slide from my presentations at professional conferences, where I show hand axes that were made by our ancestors about 1.5 million years ago, and I tell my students, hey, This is where we were about 1.5 million years ago, and this is how far we have come. So I try to connect them with this whole journey of humanity in terms of all this creative capacity we have developed over the million years or thousands of years, and how we should appreciate the creative capacity of our ancestors who laid the foundation for these innovative skills. So that's one thing, one way that I can engage my students with the topics that I teach. And the other thing is I also challenge them to be global citizens, think of a universal shared history of humanity.
Right.
So when we talk about our ancestors doing all these things on the Red Sea, we're talking about people to whom we are all related. And so, nowadays the issue of diversity and racism sometimes could...
we all grew from the same seed.
Yes, we all grew from the same seed, and the evidence lies there in those simple hand axes, but have a very important message.
Amanuel Beyin, anthropology professor at the University of Louisville. Always good talking to you.
We all know how important it is for emergency room doctors to be able to quickly diagnose and treat you when you go to the ER, and that's especially true when you have sepsis, according to doctors Richard Kim and Rodrigo Cavallazzi, both from the UofL School of Medicine, and they both specialize in pulmonary and critical care medicine. Good to see you guys. Appreciate you being here. All right, you did a study about sepsis and folks who show up with it in the emergency room. Tell me what the study was. What were you trying to figure out?
So essentially, the study that we have is we looked at the time in the emergency department and whether it was linked to mortality. That was one part. The second one was whether or not the triage to the antibiotics ordered, or which was a surrogate for our recognition of sepsis, and the triage to antibiotics given, which was the surrogate for our treatment of sepsis, if those had any mortality links in the emergency room. Yeah.
Well, I guess we ought to back up and explain to folks, what is sepsis? Let's start from the top. What is sepsis?
So sepsis is your body's kind of like overreaction to infection, any kind of infection, whether it's bacterial, fungal, or viral infections. And essentially, it's a kind of an overreaction of your body. And what happens is, if it gets too bad, it can lead to organ dysfunction or even organ failure. So, for example, if your lungs get affected, you can lead to respiratory failure, become on a ventilator. Kidneys get affected, kidney failure, etc., so on and so forth. From then on, if it even progresses even further, you can have a drop in blood pressure, and that leads to probably one of the most severe forms of sepsis, which is known as septic shock. This is extremely important because actually today, 1 in 3 people that die in the hospital, according to the CDC, 1 in 3 people that die in the hospital are actually dying from sepsis.
1 in 3?
1 in 3.
That sepsis is the primary cause of death?
Yeah. People that die in the hospital, correct.
I would have never guessed that in a million years.
Yeah, and then not only that, and it doesn't just stop there afterwards. Up to 50% of people have what they call a post-sepsis syndrome, which is not only the physical manifestations and kind of comorbidities associated with, but they also have psychiatric problems as well, depression, PTSD, things like that as well.
And just like when you come to the hospital with a heart attack, you want a cardiologist to be at bedside as quick as possible and take a look at your coronary arteries within an hour or even less than that. It's the same thing with sepsis. If you come to the hospital, you have sepsis, you want to have physicians at bedside treating and managing sepsis as soon as possible. Timely treatment of sepsis is very important.
Yeah, and we often talk about how quick, you got to have a quick diagnosis and get it treated immediately. And your study that you two worked on was to figure out how quickly, right? How quickly you need to be treated and get those antibiotics in, or isn't there some controversy about really whether you need to do that with antibiotics? So let's talk a little bit about what your study found in terms of what you were looking for when folks walk in and they're diagnosed with sepsis.
Yeah, sure. So what we were looking at was we included all people over 18 who had the diagnosis of sepsis or septic shock. So we tried to look retrospectively. Another thing that they had to have in the inclusion was a lactic acid greater than 4. Lactic acid is just a marker of poor tissue perfusion. So for findings overall, after we kind of went through all the data, we ended up with 117 patients. We found that the overall mortality from sepsis was about 47%, which is huge. But what we did find was, and what was one of our...
So half the folks that walked in that you used in this study, basically half the folks walked in wound up dying from sepsis.
Correct. The ones that are going to the ICU.
Okay.
That's what we
Gotcha,
looked at
gotcha,
primarily.
gotcha.
Yeah, sorry. So what we did find was, number one, the time in the ER, which was one of our questions that we asked, the time in the ER did not have any relationship with whether or not you're going to live or die. Both people who lived and died ended up being about 5.5 hours in each. But what we did find was that it's the time to recognition, or the time from when you walk into the emergency room to where they start ordering antibiotics, so the recognition of sepsis, that's important. What we found is survivors, or the people who did survive, were about 1.4 hours, and the people who didn't survive ended up being about 2.5 hours before sepsis was recognized. So that means we divided every hour 0 to 1, 1 to 2, 2 to 3, 3 plus. We found that with each hour, you have a 21.5% increased risk of dying from sepsis.
Wow.
Yeah.
From the recognition.
Just from recognition.
Okay.
When you talk about treatment, so the time that you walk into actually when antibiotics and resuscitation is given, survivors spend about 2.9 hours before they were treated. Non-survivors about 4.3 hours. And so with each hour increase, you had about a 16.9% increased risk of dying.
This sounds exactly like what folks tell you about stroke. What doctors tell you about stroke is treat it as quickly as possible, right, Dr. Cavallazzi?
Exactly. So recognition of this condition is very important. So it's important that the physicians and healthcare providers are aware of this syndrome, and then the appropriate and timely initiation of treatment is also very important, just like stroke, just like a heart attack.
Right. Well, I want to get on to, so we know that if the doctors identify sepsis quickly, the quicker they do that in the ER, the ICU, the better chance you have of living if you've got sepsis. That's number one. Number two, though, and here's a question. Antibiotics. Apparently there's some controversy about antibiotics and whether to administer those for sepsis. Is that correct? Am I right or wrong on that?
Yeah, so it's like the timing of antibiotics is a big thing, and whether or not to administer them. The problem is what makes it kind of tricky is that even if you meet these 2 out of 4 of these criteria that we were saying, the SIRS criteria, there are several conditions outside of sepsis that can be positive in this.
Right.
And so that's when clinical judgment comes into play, and it's extremely important, yes.
I think the controversy might be the mandate to give antibiotics within a certain time frame for every patient who meets the criteria of sepsis, because just like Dr. King said, many patients who have a high respiratory rate or a high heart rate or even fever may not have sepsis. You can come to the hospital, for instance, with a pancreatitis, inflammation in the pancreas, which is not sepsis, and have all those
I'm
criteria.
familiar with pancreatitis.
Yeah.
Personally familiar. It's not much
Oh
fun.
my God, that's not
It
good.
is not much fun.
So if you mandate providers, healthcare providers, to give antibiotics within a certain time frame, many people are gonna get antibiotics that are not needed. So that's where the controversy is. But if you have sepsis, and this is a no-brainer, if you do have sepsis, the earlier you get antibiotics, the better.
Gotcha. All right. Final word to folks out there who maybe headed to the hospital. Do people even think of sepsis, a patient, when they walk into the hospital and into the ER? And should they? Should they think, oh, you know what? Is there a chance I've got sepsis?
Yeah, I mean, it's definitely something that they should always think about. We're noticing over the years that we're having increased number of hospitalizations from sepsis. But when, for example, a patient talks to me, oh, do I have sepsis? They don't necessarily actually understand the whole scope of what's going on. They think, oh, it's a bloodstream infection or something, which is not entirely true. It's only a small piece. So yeah, it should always be in the back of mind, because as our study showed, it's always important to first recognize it, and the faster you recognize it, the faster you get treated for it.
All right. We'll end on that note. Drs. Richard Kim and Rodrigo Cavallazzi, appreciate you being on the show. Thanks for listening to UofL Today with Mark Hebert, and go Cards!